Hi, so let's talk about the concept of gas exchange with the exemplar of respiratory distress, which is exemplar 15A for you. So let me tell you how this process is going to go. With these pre-recorded lectures, you need to open the outline that's been provided for you and take notes as you listen to this. Those outlines were made for you, but you have to take them and make them into your own. So you need to take notes. At the end of every outline is some questions of the nursing process, and you need to take and answer those questions based on the concept you just studied with that exemplar and go through the nursing process, because we're nurses and the point of what we do is taking care of patients, so we need to think through that nursing process. So you've had a lot of these concepts before. What we are going to do is continue with what you know and talk about more critically ill patients, and specifically for respiratory failure, patients who are in respiratory distress and who will possibly need to have a artificial airway put in and be placed on mechanical ventilation. So the first thing you need to review is these principles and concepts in the care of a patient with a gas exchange issue. We're also have several interrelated concepts that we're going to talk about, one of which is acid-base balance. So you need to go and review ABGs. So I know that you have learned ABGs, but this semester we are going to add compensation, which is going to change how you look at and identify your ABGs. So if you have not looked at that, you need to stop this video, go over and look at the soft talk file for ABGs. There's a step-by-step process, so pull that ABG interpretation page out so that you can follow that step-by-step process. And on every page, I have recordings explaining the process. We're going to do it here, but we're going to do it much faster. So go do the ABG first, and then come back here. Our other interrelated concepts are comfort and nutrition. So you have what I call fast facts. So that's a page or two of information that you need to know. So you already know things about comfort, and you know things about nutrition, specifically tube feedings, because that's where we're going to go. And so you need to review those. Now, in your comfort, we've added procedural pain, talking about doing specific procedures like cardioversions, bronchoscopies, things like that we may have to give sedation, and sedation and comfort measures related to things like mechanical ventilation. So look at those as well so that you know what we're talking about. So that's all there for you in Blackboard. All right, so let's do our ABGs. So this is where things are going to change. When you name the ABG, and naming it, you're calling it respiratory metabolic acidosis alkalosis. The only pH you are going to use from now on when you name it is a pH of 7.4, because that's a normal pH. We will use the range of pH of 7.35 to 7.45 when we talk about compensation, which is several steps in the interpretation process. Compensation is the body adjusting things to get itself out of an acid-base imbalance back into balance. So if the body is acidotic, then the compensatory mechanism is to increase bicarb so that I move closer to a pH of 7.4. If I'm alkalotic, then I need to increase the acid, so I move back into a pH of 7.4. So you do need to know your normal values. So your pH is 7.35 to 7.45, but when you are naming it, the only pH you're going to use is 7.4. PaCO2 is an acid. It is regulated by the lungs. It works quickly, so it's the first bit of compensatory mechanism that we see for acid-base imbalance, and a normal PaCO2 is 35 to 45. PaCO2 is an acid, so the higher the value, higher than 45, it is an acid. If it's less than 35, it's not acid anymore, it's alkalotic or base. Bicarb and normal bicarb is 22 to 26. That is regulated by your kidneys. As the kidneys produce bicarb, retain bicarb, and that takes several days for compensatory mechanisms to work. If your bicarb is higher than 26, you are more alkalotic or base. If you are less than 22, you can't be alkalotic, you are acidotic. So if you will look at this little picture up in the upper right hand corner of the slide, you will see that we have the values listed. The PaCO2 is listed backwards because what this does is it puts all the acid on one side, all the base on the other side. I learned this in a conference I went to and have taught it this way since, and students really like it. So it's important that you use the pH of 7.4. The last piece of your ABG interpretation is looking at the oxygenation, which is a piece that I have added on, that last step. And you're going to look at your PaO2 and your SaO2. So FYI, this A means arterial. This is arterial blood gas that we are looking at. So this is my PaO2, and normal PaO2 is 80 to 100. That's the value we're going to use. And then SaO2 is your O2 sat. So when you get a blood gas on your patient, and if you're in the ICU or a place that's doing continuous pulse ox monitoring, you need to look at your SaO2 and your gas and look up at your monitor and see where your O2 sat is, and those should be the same numbers. All right, I have 3 examples. I'm going to show you the example. I'm going to pause for a few minutes, for just a couple of seconds. You pause the recording. You do your A for acid, B for base, N for normal. Figure out your acid-base imbalance, and then turn this presentation back on and see if you got it correct. So our first example has a pH of 7.33, our PaCO2 of 40, and a bicarb of 21. So take a few minutes and analyze this gas. All right, so I hope you paused and see if you can analyze this gas. So the interpretation of this gas is metabolic acidosis. So we're going to start with that. My pH is less than 7.4, so that's acid. My PaCO2 is normal. My bicarb is low, so it's acidic. This would be an A. This would be an A, so I have a matching bicarb and pH. That's metabolic acidosis. Compensation rules. There's 3 rules. The way you memorize things that have like 3 rules, you get 2 of the rules down, and if you can say it's not that one or not the second one, then you know it's the third one. That's the easy trick. So an uncompensated gas means your pH and one other value is abnormal, which is what we have here. A partially compensated gas means the body's trying to fix it, hadn't quite got the pH back in that normal range of 7.35 to 7.45, but it's working on it, and all 3 values are abnormal. A completely compensated gas has the pH in the normal range of 7.35 to 7.45, and the PaCO2 and bicarb will both be abnormal. So you'll have a normal range of pH and abnormal PaCO2 and bicarb. The way you know what started that compensated gas is going back to the history of what is wrong with the patient. Is usually how you tell that. All right. Let's look at a second one. So this is a partially compensated respiratory acidosis. The pH is low, so it's acid. The PaCO2 is high, which means I'm more acidic. And the way we're going to compensate for that is we need to have more base. So my bicarb's going to go up. So all 3 values are abnormal. It means the body's trying to fix it, but it hasn't got it there yet. So this is a partially compensated respiratory acidosis. The reason compensation is important is if the body has compensated, we don't need to do anything for the patient. We need to leave them alone. Because if we start messing with them, we're going to screw them up. The best example is a patient with chronic COPD. So a patient with COPD retains PaCO2. They have a hard time getting rid of the PaCO2, which means they will be acidic. So their pH will be low, their PaCO2 will be high, but the compensatory mechanism is to increase bicarb, so it's going to be high. And when the pH gets back in a range of 7.35 to 7.45, that patient is now compensated. The body, their own body, has put that acid-base imbalance, think of it as scales, back in line, and that's where that patient lives, and we need to leave them alone. All right, one more ABG. Okay, so this is a compensated respiratory alkalosis problem. So let's look at this one. My pH is 7.45, which means when I name it, it's going to be a base. My PaCO2 is 34. That is less than 35, which means it is base. And my bicarb is 20, which means it's acid. So the PaCO2 and the pH match. That's respiratory alkalosis. But because my pH is in the range of 7.35 to 7.45, this is a compensated gas because the body has reduced the amount of bicarb to offset the fact that this is alkalotic. All right, be sure that you look at your ABGs. I will tell you now, the test answer is not uncompensated metabolic acidosis. It's analyzing an ABG, knowing what it is, and knowing what we need to do, if anything, for that patient. Because if it's a compensated gas, there's probably nothing other than to continue to monitor that patient. So you got to understand how to analyze them and what it means for the patient and what it means for you as a nurse. Okay, so we're going to just do an overview of what respiratory failure is. That's what this presentation is going to be, and then we're going to dive into that exemplar of ARDS, which is 15A. So what happens in respiratory failure is we have an inability of the respiratory system to provide enough oxygenation and or ventilation. So oxygenation, that's the easy part. I breathe in oxygen, I take a deep breath in, my alveoli expand, I have gas exchange, the O2 goes out through the is moved from my alveoli out into those capillary beds. The CO2 replaces the oxygen, and then I exhale and blow off my my CO2. So oxygenation issue means I don't have enough oxygen. Ventilation is the removal of the CO2 when I have a problem with that. So what you will hear and see in charts is that they may have a hypoxic respiratory failure or a hypercapnic failure, or both. So a hypoxic respiratory failure, by definition, is a PaO2 less than 60. They are hypoxic. There's inadequate exchange of oxygen. Less than optimal PaO2 levels exist despite the fact that they're on supplemental oxygen. So we're giving them oxygen, but it's not helping. We have low levels of PaO2. So think to yourself, what would somebody look like with low levels of PaCO2? What might the first sign and symptom be? And it might be something like restlessness. Hypercapnic respiratory failure is a PaCO2 greater than 50. So they're in what acid base, I started to tell you, what acid base imbalance would they be in if their PaCO2 is greater than 50? They would be in respiratory acidosis. And what is happening is we're not removing the PaCO2. And the best example of what that person looks like is a COPD patient. So you may have somebody with hypoxic respiratory failure, hypercapnic respiratory, hypoxic and hypercapnic respiratory failure. You also may have somebody who is acute on chronic respiratory failure, and that is somebody who has COPD. Respiratory failure occurs rapidly over minutes to hour, and there's no time for these compensatory mechanisms our body has to fix this. And those compensatory mechanisms are, think about it, if I can't breathe, My body's like, hey, I, I'm not getting enough perfusion, tissue perfusion. Lungs, breathe deeper, breathe faster. And then your body's like, I don't really know what the problem is, but you know what? Heart, you beat faster. You beat harder so that I can get more perfusion as well. And your blood vessels kick in and say, you know what? Let's vasoconstrict so that we can have this good perfusion and gas exchange to all of our organs. So that is what respiratory failure looks like, or what the definition of respiratory failure is. What I want you to think of is, what do these patients look like? How, what does somebody look like who's in respiratory failure? It makes me kind of shiver, makes me fairly nervous when somebody is having problems breathing. This isn't just a little shortness of breath. This is really struggling to breathe. Think about what that looks like. They're going to have increased work of breathing. They're going to be using accessory muscles. They might even actually have retractions. They may have nasal flarings. Those are all things that we know in our pediatric population. Not good in PD, but certainly not good in an adult. These patients need to be setting up. Probably they already are. Somebody who can't breathe is not going to be laying down flat in a bed. They need to set up. They're going to need some oxygen. So we will talk quickly about some interventions that we're going to do for respiratory failure before we move into ARDS. So just keep thinking about, what are you going to assess? What questions do you ask? So let's look at the causes. So your details are in your outline. So the first one is something like lung disease. So something like pneumonia, atelectasis, COPD, asthma. This could even be somebody with cystic fibrosis, because we will talk about that as well. Fluid buildup in the lungs. Well, that sounds like heart failure. Pulmonary edema, pulmonary embolism, near drowning, those sorts of things. Muscle and nerve conditions. So these are people with neuromuscular disorders. So think of Guillain-Barré, myasthenia gravis, ALS, those neuromuscular diseases that lead to respiratory failure. Spinal cord injuries. If I have a C2 spinal cord injury and I have my spinal cord is severed, then I will no longer be able to breathe on my own. I will be I will have quadriplegia, and I will be on a ventilator forever. And can be strokes, certainly in the acute phase of strokes in respiratory failure, because that stroke may have taken out the brainstem and the respiratory center of the brain. Chest injuries, so this is traumas. Injuries to the lungs or ribs, drug or alcohol overdose, so suppression of the brain and the respiratory center, and non-pulmonary, so think of things like low cardiac output states. Probably the best example of that is sepsis, low hemoglobin. If I don't have enough hemoglobin to carry my oxygen, then I'm going to have breathing problems. Heart failure certainly falls in low cardiac output states, certainly falls in fluid buildup in the lungs. It's however you want to think of that. Okay, so let's talk about how we're going to fix this. So I kind of like how this is written, because when you see each one of these, maintain a patent airway. Well, what does that mean? That means I need to make sure that my patient has a patent airway. I need to provide them with oxygen. I might need to have them intubated, an endotracheal or ET tube put in. That is done by respiratory or a healthcare provider. As a nurse, I do not put in an ET tube. I do not DC an ET tube, extubate a patient. But I take care of the patient. I monitor that patient, monitor the tube, monitor the ventilator, and all of those types of things. So I've got to have a patent airway. I need to optimize O2 delivery. These people can't breathe, so I need to give them plenty of oxygen and make sure that they have it. So how am I going to do that? Well, you can start with the nasal cannula. You may have to move to a face mask. We may need to move further on to higher things. If you're on the floor and you have somebody who's so short of breath and in respiratory distress, and you need to put a face mask on them, like a non-rebreather, which is about 90% oxygen, are you going to keep that patient on the floor? No, you need to have that patient. You need to call an RET and move them to the unit. Minimize O2 demand. Bad rest. These patients don't need to get up and go to the bathroom. They can use a bedpan. We need to minimize how much oxygen they're using because they don't have enough doing just laying in the bed. So I need to make sure that we are not using all their oxygen. I want to make sure that I've got a PaO2 higher than 60. I want that O2 sat higher than 95. If it's a low hemoglobin issue, I want to transfuse, give them blood products. If it's a low cardiac output problem, then I need to give them a blood pressure. I need to treat the cause, whether it's ARDS, COPD, asthma, pneumonia, sepsis, put a chest tube in, all of those kinds of things. And then I need to prevent complications. And those biggest complications are immobility. So what are they at risk for? Adverse effects of medications, specifically giving sedation, fluid and electrolytes. They're at risk for gastric ulcers, problems from mechanical ventilation, specifically ventilator-associated pneumonia, or VAP, which we'll talk about later in another recording, and psychosocial, psychological problems from being intubated in an ICU where you can't do anything for yourself. So think about how you're going to take care of this patient, what this patient looks like, go through the nursing process with respiratory failure. We will start ARDS in the next recording. Thanks.